A very big hello to all my dear students. So today let's start with orbit. All of you give the heading orbit. We start with the diagram here. First we will draw this orbit. I think this diagram we have done in the introduction chapter as well. So first question here is, what is the capacity of the orbit? We'll answer 30 cc. Next question from the orbit is, what is the shape of the orbit? We will answer, it is quadrilateral or pyramidal in shape. I think these two questions have already been done as well, but we have to repeat it here. It's important, right? So this is actually double Qs asked many times about the capacity and the shape of the orbit, right? Okay, so once we know this, let us all see this slide here. What is this showing you? You should be very, very clear what is the base of the orbit and what is the apex, right? So base is this one, and when we say apex of orbit, we are talking about this area. Everybody has learnt in anatomy also, we are just revising here. Talking about the alignment of the two orbits, the medial walls are parallel to each other, as you can see here. Whereas the angle between the medial and the lateral wall is 45 degrees, right? So if you see here, it is more like divergent, isn't it? So this is one orbit, direction one, orbital axis is this, and this is the other one. So it is divergent orbit. So what we have to learn here from this slide is one important thing, that the angle between the medial and the lateral is 45 degrees, right? Okay. We talk next about what are the different bones which form the orbit. Okay, we'll learn it by thinking ourselves. This will not help. So let's think and write ourselves. What are the bones? We start with the roof. So first learn with me. Roof is 2 bones, lateral wall 2 bones. Then coming to floor, it is 3 bones, and medial, it is 4 bones. Simple, 2, 2, 3 and 4. So when you talk about the roof of orbit is formed by, think yourself with me, frontal to hai. So one is your frontal bone, and apart from the frontal bone, it is lesser wing of sphenoid, right? Lesser wing of sphenoid. Done. Then we talk about lateral, again 2 walls. Think of what wall? This is zygomatic. So we will say zygomatic, and so one is zygomatic bone and greater wing of sphenoid. Greater wing of sphenoid. Okay? Come to the next one is your floor. Floor of the orbit, 3 bones. Zygomatic, maxillary, and at the back small palatine. So write down zygomatic bone, maxillary, and a small palatine bone. And then we talk about the medial wall. Medial wall is formed by 4 bones. Let's think together. Maxillary, behind that lacrimal. So first is frontal process of maxillary. After that maxillary bone, behind that is your lacrimal. You all remember, lacrimal is the one which you are breaking in dacryocysto-rhinostomy. So lacrimal bone. After lacrimal bone, go back more. It is cribriform plate of ethmoid sinus, right? So cribriform plate of ethmoid sinus. When you say cribriform, you all are clear what it is? Lot of pores. This is called lamina papyracea. You all must be knowing this name, lamina papyracea. And then comes your, which is the next bone in the medial wall, is body of sphenoid. Body of sphenoid. So these are the bones which are forming the orbit. Which is the weakest wall? A very, very important repeated question and a debatable question. Weakest wall of the orbit, please answer medial. Okay? Why it is the weakest? Weakest wall, we have a reason here. Weakest because of the cribriform plate of ethmoid. This is vulnerable to breaking fast. So this becomes the weakest wall. That is medial wall. Due to, you want to write it, due to cribriform plate of ethmoid sinus. Okay. And if your question is, what is the wall which is broken in the blowout fractures? You all know what is blowout fracture? It is a fracture due to blunt trauma. We are going to take it in detail at the end of this chapter. So if they ask you blowout fractures, I am discussing here because this is the point of confusion. So now blowout fractures are term given to the fracture floor of the orbit. Okay, so we'll say fracture floor. There was one question, which is the weakest part of the floor. When you say weakest part of orbit, weakest wall of orbit, it is median. Weakest part of floor is posteromedial part. Okay, so it is posteromedial part. Right? Okay. We next talk about the different fissures. Have a look. We all know this is supraorbital fissure. It is between the gap between what and what? So you can see here, roof is formed by lesser and this is the greater wing. So it is between, this one is your lesser wing of sphenoid and between the greater wing of sphenoid. So between the two is your supraorbital fissure. We next talk about inferiorbital fissure. Again, you will say it is formed between the greater wing of sphenoid and the, what is this? Maxillary bone. Right? So you will say it is between greater wing of sphenoid and maxillary bone. Right? This is your inferiorbital fissure. An optic foramen, of course, you can see is a part of the roof. This is the lesser wing of sphenoid, a part of roof. We also have a notch here. What is this notch called? Supraorbital notch. So this supraorbital notch, you all remember, peribulbar injection anesthesia is given through this. Just keep this in mind. This is your supraorbital notch. So these are the things we are going to remember for the fissures and notch. Then anything else we will discuss in anatomy? Very, very important diagram. Are we not familiar with this diagram? We have learnt in anatomy also. So this is your supraorbital fissure, this is the inferiorbital fissure, and this is your annulus of Zinn. AZ is annulus of Zinn. Right? So we all know this is optic foramen. What are the two structures passing? Just have a look at this diagram. We are going to draw it for ourselves. So it is the optic nerves, cranial nerve 2, that is optic nerve, and ophthalmic artery. Right? So these are the two structures passing through optic foramen. Then talking about through supraorbital fissure, what are the nerves passing outside the Zinn? What are the nerves passing outside the Zinn and what are the nerves passing inside the Zinn? We all remember the mnemonic LFT? Okay, let's write it here. We'll first make this diagram of supraorbital fissure. Yeah, and this is the supraorbital fissure and this is the annulus of Zinn. Right? First question they have asked you is, what is annulus of Zinn? This is your exam question. So we all know what is annulus of Zinn. It is a tendinous ring from where, don't answer all the muscles, it's a wrong answer. We will answer all four recti originate from annulus of Zinn. So it is the origin of all four recti muscles. Origin of all four recti muscles. I should draw it also. So this is your supraorbital, inferiorbital, annulus of Zinn. What are the nerves passing outside? LFT, lacrimal, frontal, trochlear. This is the third nerve, two divisions with nasociliary, and this is your sixth nerve, abducens. This is nasociliary. These are the two divisions of third nerve. Am I now clear? This is your superior ophthalmic vein is this one, and this is your inferior ophthalmic vein. And here comes your zygomatic nerve and infraorbital nerve. Okay. So we were talking about what is here is optic foramen. Right? So when you say optic foramen, if this is the optic foramen, what are the structures passing through it? Two main structures are passing. One is optic nerve and second is your ophthalmic artery. Okay? So this is ours. What are the structures passing through optic foramen? So we can say it is optic nerve and ophthalmic artery. I think this one is a better diagram. You can just follow this one. Right. So this was about your supraorbital fissure and inferiorbital fissure and what are the structures passing through it and what are the structures passing through optic foramen. Now, a quick description of two more things from the anatomy part of the orbit. First is your orbital fascia. So when you say orbital fascia, keep in mind we are talking about two main things here. What are the things? One which is lining the periosteum, that is called periorbital fascia. Okay. So periorbital fascia is one, learn with me, it lines the periosteum. Right? I'll tell you where they have asked you a question and why we are studying this. Second one is your bulbar fascia, which you have learned as Tennant's capsule. right? So bulbar fascia, which is also called Tennant's capsule. So this not only forms, as you know, it is just above the episclera, but it is also forming the muscle sheath, extraocular muscle sheaths. So it also forms the extraocular muscle sheaths. Now what happens is, if you talk about this bulbar fascia, this one is responsible for, so it gives rise to two things. This is what you have to know. One is your medial and lateral check ligaments. This medial and lateral check ligaments are actually helping in the horizontal stability. Check ligaments which help in horizontal stability of your eyeball, right? Or lateral stability, you can say, not horizontal, say it more lateral stability or horizontal, right? And when you talk about second important thing is your suspensory ligament of Lockwood. So next important thing, it forms as, one was this one, and second is your suspensory ligament of Lockwood. Now this was your exam question. We are going to talk about this ligament of Lockwood. This is actually formed by all from the muscle sheath, okay, facial sheaths of all muscles except the superiors. We are talking about inferiors, medial, lateral. So it is from facial sheath of all muscles. Except superiors, that means except superior oblique and superior recti, right? And this suspensory ligament of Lockwood is going to prevent any downward displacement of your globe or eyeball. So it is giving what? Vertical stability. This is giving you a vertical stability and prevents downward displacement of the eyeball. Prevents downward displacement of eyeball. Right? Okay. And then lastly, we should also know about the different spaces in the orbit. It can be asked. We'll make these are surgical spaces which we talk about. So I had discussed these spaces when I was talking about peribulbar and retrobulbar anesthesia, right? So what are these surgical spaces? Let us draw this to understand if this is your orbit and this is the eyeball, correct? Simple. Now, between the periosteum, right, and the bone, if this is the periosteum, draw this periosteum. What is this is one thing. Then this is your bulbar fascia where all the extraocular muscle sheath is attached from here and the Tennant's capsule like this. So if these are the muscles and the extraocular muscles on the eyeball, on the sclera, on the bulbar fascia, right? So if these are the muscles, did we realize this, that the space between all these muscles which are coming and inserting on the eyeball, this becomes your very simple intraconal space, right? Muscle cone ke andar, inside the muscle cone. And we are giving a retrobulbar injection is mainly given in the intraconal space. Whereas when you talk about outside, this becomes your extraconal space, and extraconal space is a space where you are giving the peribulbar anesthesia or peribulbar injections. It could be no anesthesia or anything else also, any drug, steroid, something. So peribulbar injections. And below the periosteum, this becomes subperiosteal space, right? This is your subperiosteal space, right? And the space between the eyeball and the Tennant's, this is what is subtenon space. We give injection, subtenon injection, we have learned this. So this is your subtenon space. So these are the four spaces, so simple that you have to know. Subperiosteal, subtenon, extraconal, intraconal. Easy? So that was about the anatomy part. We now next talk about what is proptosis. Give the heading proptosis. So proptosis, what is proptosis? We all know proptosis is protrusion of eyeball. Now how much protrusion? If somebody has nice big eyes, do we call it proptosis? No, that's not fair, right? So how are you going to measure proptosis? It is from the lateral orbital margin to the apex of cornea, right? So how do you define proptosis? We just can't say protrusion of eye. We will say the distance between the lateral orbital margin and apex of cornea. And apex of cornea. How do I know which is the apex of cornea? When you show light on the cornea, the light will shine only on the apex. So this is more than 21 millimeters, or the difference between two eyes of more than 2 millimeters. This is how we define proptosis, right? So when you say proptosis, how are you going to measure this distance? I can do it with a simple scale, but the instrument is exophthalmometer. How you are measuring is exophthalmometer. Which is the commonest one, which you should know is Hertel's. In children we use, so I'm talking about the names of exophthalmometer here. So Hertel's, in children the instrument that you use is called Lutz exophthalmometer. And suppose if your proptosis is not axial. Everybody understands what is axial and non-axial? When it is protruding in the straight line, it is axial. In different directions, it is non-axial. So if it is a non-axial proptosis, then it is Naegele's exophthalmometer. Now, we don't have to go into too many details here. We will just know the name. So Naegele's exophthalmometer is for non-axial proptosis. Got it? Okay. So once you know this, or you can do it with a simple scale I just said, but the instrument is this. So they have asked you about Hertel's, so we will make a cue here. Are there any other clinical tests, clinically when the patient is in the OPD and I'm not exactly measuring, but do I know, will I be able to know whether there is proptosis or not? If it is a frank proptosis, it will not be any confusion. But what are the different tests? I hope you all remember the Naviger's test. What was that? You stand behind the patient. So if the examiner is behind the patient is sitting on the chair, and then you elevate the chin of the patient. So the eye which is outside the supraorbital rim. So which one is outside or which appears first is the eye which is protruded out. This is your Naviger's test. See here. So this is the clinical examination of the orbit which is taking place from the behind the chin of the patient is being elevated, right? So what we see is which eye is protruded we can have a very exact idea. So we have to see the protrusion from this supraorbital margin. Okay, then what is the worm's view? When you're seeing it from front, if I see it like this, I can see that this eye is protruded. So this is your worm's view. You should just know what is a worm's view in examining the proptosis. Right? Okay. This is your exophthalmometer where we are measuring the exact distance from lateral orbital margin to apex of cornea. This is your Hertel's exophthalmometer. Okay. So before we come to proptosis, we now know what is proptosis, how are we going to measure it, right? And how do you classify proptosis? How do we classify proptosis? It can be painful or painless. Number one way of classifying is it can be painful or painless. This is one way of describing it. It can be unilateral or bilateral, another way. And third, it can be axial or it can be non-axial proptosis. Whenever the eye is non-axial, what do you call this? Dystopia. Okay. Dystopia is how much away the eyeball is from its axis, away from the normal, right? Dystopia, deviation, right? So this is how you are going to, I shouldn't be saying deviation exactly, I meant mainly we use this term for non-axial proptosis, correct it. Okay, so this is how you classify proptosis. This is how we describe proptosis. Simple? Easy? Okay. Then coming to first, now we are going to learn about the different causes. Whatever is important for you, we are going to pick up those topics. Now before that, first thing is what is pseudoproptosis? So what is pseudoproptosis, all of you? So the eye is not protruded, the distance between the lateral orbital margin and the apex of cornea is normal. But still, I feel on clinical when you are looking, one eye is out, one eye is in, right? So what are can be the causes where it's not actual proptosis? What can be the causes? Let's learn. Number one, high myopia. So big eyes can be confused with a proptosed eye. So number one is high myopia, or if there is eyelid retraction, it may look like the eye is protruded. Do you all know what is eyelid retraction, all of you? So what is the normal position of your eyelid, upper eyelid? Just below the limbus, 2 mm, covering 2 mm of the cornea. And lower eyelid just touches the limbus. So upper eyelid is 2 mm below the upper limbus, but lower eyelid just touches the limbus. We are going to discuss that in eyelid also. So whenever your lid is below its normal level, you call it ptosis, and when it's above its normal level, we call it lid retraction. So what is this? This is lid retraction. Okay, so that could be another cause which can give us an impression that there is a proptosis. Third, if there is a contralateral ptosis, then you may feel that okay, this one eye is protruded. Similarly, there can be contralateral enophthalmos. You know what is enophthalmos? When the eye goes inside, that is called enophthalmos. Or shallow orbit. I don't want you to mug it up, please. Just know it. Just read it twice and thrice and you will know what are the different causes of pseudoproptosis. Just think logically what it could be. Right? Okay. Now we take one by one. Most important cause of proptosis, especially in adults, whether it is unilateral, bilateral, any combination is possible. We are talking about what? Thyroid eye disease. So give the heading, thyroid eye disease. Very, very important topic. Thyroid eye disease is also called Graves' ophthalmopathy. Write down, it's also called Graves' ophthalmopathy or Graves' eye disease. It is an autoimmune disease, we all know this, more common in females, right? More common in females, generally presenting in the middle age. And very, very important point, we put a double Q here, it is not related to thyroid hormone levels. So the thyroid may be more, it may be less, it may be normal. So we can write like this, that patient can be euthyroid, normal thyroid levels, it can be hypothyroid, or it could be hyperthyroid, right? Any possibility, anything is possible, but still the patient can have this thyroid eye disease. Please keep this in mind. So if you are asked that which is the most common cause of proptosis in adults, is it unilateral proptosis, bilateral? In both cases, our answer will be thyroid eye disease. Okay. So this is the next important point we will note down. It is the most common cause of proptosis. Whether we are saying unilateral or bilateral, we say axial, non-axial, whatever. Okay. Every combination we have to answer this only, and that is your thyroid eye disease. We are talking in adults. Right, and if suppose for children, if they ask you, let me solve this question also for you. For children, what is the most common cause of unilateral proptosis and what is the most common cause for bilateral proptosis? Right, so if these are all your exam questions, you can make a Q here. So if they ask you this most common cause for unilateral, our answer will be orbital cellulitis. Right, and for a bilateral, it will be neuroblastoma. Okay, neuroblastoma. Let's come back to thyroid eye disease. First of all, clinical features. It will present with five main salient features. So what are the salient features of thyroid eye disease? First, of course, is proptosis, optic neuropathy, okay, optic neuropathy, myopathy, soft tissue signs and lid signs, soft tissue signs and lid signs. So these are the five salient features of thyroid eye disease. Okay, so what is the pathogenesis? Why are we getting this? And then I'm going to go into details of each. Okay, so first we talk about is when you say, okay, let's write here only, I think it will be easier. For proptosis, I have already told you every combination can be possible. Unilateral, bilateral, painful, painless, axial, non-axial. Can you note down this for yourself? Painless, axial or non-axial. We can write this much here. Right. Now we talk about the pathogenesis. Next heading will be, we'll draw a diagram here. Pathogenesis. It's an autoimmune disease, we all know that. What exactly is happening? There is antibodies against the thyroid gland cells and the orbital fibroblasts. So this is the eyeball, optic disc, optic nerve. Let's make this much, right? So what did we say? In the orbit, due to the autoimmune disease, due to the autoimmunity, there are antibodies against the thyroid. So let's write it here. What is happening is antibodies against orbital fibroblast and thyroid gland cells. Antibodies against thyroid gland cells and orbital fibroblasts. Orbital fibroblasts. Now when these antibodies are formed, now this part of autoimmunity reaction, what next happens is inflammation. So because of this, inflammation of extraocular muscles here, okay, the muscles are attached like this. So first is inflammation of extraocular muscles, right? So they are enlarged. Then infiltration of inflammatory cells. So number one is extraocular muscles are inflamed. Second, write down infiltration of inflammatory cells due to this autoimmunity. Then write down multiplication of adipose cells. Number three, multiplication, please make the diagram, it will become easy for you, of adipose cells. Don't write in a bookish manner. This will help you more, right? Right. And what else is happening? Even inflammation of the lacrimal gland, if you want to note down. And there is increased secretion of, very important, number 4, increased secretion of glycosaminoglycans, increased secretion of GAG. So this is the pathogenesis, right? Got it? So inflammation of inflammatory cells, number 1, inflammation of extraocular muscles. So they get enlarged. When the extraocular muscles are enlarged initially, later there is fibrosis, but initially they are enlarged. Then infiltration of inflammatory cells. Then multiplication of adipose cells. Increased GAG in the, what is happening? It is a hyperosmotic, it will imbibe on. So what is happening is, ultimately there is more pressure inside the orbit. Okay? The capacity of the orbit is 30 cc. But now the pressure has increased. Which pressure? I am talking about orbital pressure. So when the increased intraorbital pressure is happening, what next will happen is, it will push the eye out, causing proptosis. And common sense, this will also press on the optic nerve, leading to, let us note down, leading to compression optic neuropathy. Whenever the nerve is not feeling well, there is a neuropathy. What did you learn with me? All those 5 features: decreased visual acuity, afferent pupillary defect, decreased color, decreased brightness, all those things that you talked in neuropathy. You have to remember here that whenever the nerve is compromised, all those features start appearing. Right? So one by one, first we are talking about that this more increased intraorbital pressure has caused pressure on the optic nerve, it has caused proptosis. So the point is how to manage this. So pressure on the optic nerve, how it is manifesting? What did I tell you? Optic neuropathy will manifest as all signs of optic nerve disease that we have studied. Right? Which I just mentioned. So how to manage this? How to treat this problem? These two problems. It's all due to more intraorbital pressure. Intraorbital pressure is more due to autoimmune reactions. So we start with systemic steroids. Okay? So we start with systemic steroids. And if this is not working, now we have a new group of drug that needs a mention here. So let us learn one by one. So immunosuppressives can be given. And here we are talking about, one is tocilizumab. We have learned these names earlier also in the previous chapter. Right, this mainly works against interleukin 6. These are all inflammatory markers. Okay, if you want to learn it, okay, otherwise it's not needed. Then second you will learn is infliximab. We know this, right? This is again against your tumor necrosis factor alpha, again inflammatory factor. And third is your adalimumab. We had learned this also. Adalimumab generally works against your transforming growth factor. Let's not talk about the factors if it's not that important at your level. Just know that these are the other drugs that I can give if the steroids are not effective. Okay. One more, a new one that you should know, the name is Tepro. Okay. So we will learn as teprotumumab. Difficult for me also. But just know it as a one line. This is one extra point. If you don't want to know it, even this is okay. They have not asked you yet. So teprotumumab is another drug which is found to be very effective in thyroid eye disease. Right, if this is also not working, or this along with that, we have also another modality is radiotherapy, and what we use here is an anti-inflammatory role of radiotherapy. Right? And what is the third option? If nothing is working, I can't let this proptosis and intraorbital pressure keep increasing. It can cause an irreversible damage to the optic nerve and the patient can become blind. So in a very severe condition, if nothing is working for us, what we can go for? Right? Then we can go for surgery. What is that surgery? Main problem is more pressure in the orbit. So we will try to decrease that pressure by decompression surgeries. Okay? So we will learn about decompression surgery. How can you do this? How can you decrease the pressure? Should I take out things from the orbit? No, that's not practical. So what we do, we increase the capacity. We break the walls of the orbit. Okay? So we break the walls of the orbit. It could be generally 1, 2 or 3 wall surgeries more commonly done. So first, this is an exam question. What is the first wall to be broken? Right? Earlier years we were answering medial, but we will now answer first deep lateral. Then comes your medial. Okay? And medial, then inferior, and then lateral. Again, MIL, mother-in-law. Okay? But first you will say deep lateral now as an answer. So this has changed, keep in mind. And then the sequence will be like this. So this will be deep lateral and medial as one. This becomes your 2 wall surgery and this becomes your 3 wall. Then 4th wall, disturbing the roof is a very tricky thing. It is rarely done. Okay. Yeah. Then we talk about, so this is all you have to know about the decompression surgery at your level. Now, we managed this, we talked about proptosis and optic neuropathy. Coming to next was myopathy, isn't it? Look at the diagram here. Go back to your pathogenesis. What is happening? The muscles are enlarging, but this is later on, the inflammatory process will lead to fibrosis. And any fibrosis, it is just opposite of palsy. So it is not paralysis, it is restriction now. We call it restrictive myopathy. Okay? So next is your heading is, it can lead to, you have learnt in your 5 features, silent features, myopathy. And what myopathy? We will say it is a restrictive myopathy. Now when you say it's a restrictive myopathy, again features are going to be same whenever there is a muscle problem, whether it is palsy or it is restriction. There is going to be diplopia and there is going to be squint. So these 2 features will be there, diplopia and squint. And therefore what do you do? The treatment would be squint surgery. Very, very important series of questions out here. Let's learn one by one. First question. Which is the first muscle to be involved? First muscle to be involved, we are going to answer is inferior rectus. Okay? And what can be the sequence of the recti involvement? Let us learn with this diagram. You'll see this diagram in my book also. So everybody knows about my book, Review of Ophthalmology. The 7th edition is available there. Right? You should know it. Just have a look at this, that as well. So this is your inferior rectus. This is your medial rectus. This is your superior rectus and lateral rectus. Right? This is the sequence of how the recti are involved. Next question. Next question is, which is the last muscle to be involved? For that, it is mainly the obliques, but if we have to choose which oblique, we will answer inferior oblique. Majority of the books say obliques, but if you have to choose, you will say inferior oblique. Then next question. This was actually the series of questions consecutive year they were asking from thyroid eye disease. So the third one they asked is, which part of the muscle is involved? So which part of muscle is involved? We will answer it is the belly of the muscle. So the tendons are spared, origin insertion is spared, it is only the belly of the muscle which is involved. I'll just show you this slide also. Right. Then we talk about another question. Which is the first defective movement? Please keep making the cues. So what will be the first defective movement that is detected in a thyroid patient? This is what they are trying to ask. Which one is the first defective movement which is detected? So first movement which becomes defective, if you think of first muscle was inferior rectus, don't answer depression. It is not palsy, it is fibrosis. So actually it is the elevation which is defective. Okay, so you will answer it is elevation because there is fibrosis of inferior rectus. Okay, one more question. How do I know it is fibrosis or palsy? What is the test known as, all of you? Forced duction test. So we call it forced duction test. So when you say forced duction test, let's understand from me. What is forced duction test? कैसे करते हैं? So suppose the patient is coming to you with defective elevation. The eye cannot move up. Right? Now hold the superior rectus with the forceps and try to move up with the forceps. If it can go easily up with the forceps, that means it is just palsy. Which palsy? Defective elevation is, so which muscle palsy we are talking about? Superior rectus. Right? I am saying a patient has come with a defective elevation. So two things can happen. Either superior rectus palsy or inferior rectus fibrosis. Hold the muscle with the forceps. Try to move the eye up. If it goes up easily, this is superior rectus palsy. But if it is stuck even with the forceps, so common sense, there is fibrosis in the inferior rectus. Correct? So this is what is called forced duction test. Hope it's clear. So these are some important questions on myopathy, which is a restrictive myopathy. Okay, we next talk about is soft tissue signs. What are we going to learn for the soft tissue signs? What are the things that you can see here? Let's have a look at the slides also. Let us first write. So soft tissue signs, first of course, that can be conjunctival congestion. Any conjunctival congestion, we have a name here, we call it Goldziher sign. Okay. Second, of course, will be chemosis, which is conjunctival edema. And any chemosis is what is called Enroth sign. So please, it is not that these terms have become now obsolete or something like that. It is still very frequently used. You have to be familiar with it. Though they have been given long back, but they are used. Then chemosis. Then what else am I going to get is superior limbic keratoconjunctivitis. The name itself says at the superior limbus there is congestion and involvement of both cornea and conjunctiva. Superior limbic keratoconjunctivitis. This has been asked as a one-liner. It's a feature of, you have to answer, thyroid eye disease. Sometimes along with this, you may also get mucus deposition. And therefore, if I want to treat this condition, I can decongest with adrenaline eye drops. And along with that, if I have to dissolve the mucus, we give acetylcysteine eye drops. Make sense? Okay, then what are the other soft tissue signs where you can also think of is when there is a proptosis, there can also be exposure keratopathy, which can be considered more like a complication, right? So exposure keratopathy. This is another corneal involvement in the thyroid disease. So these are the soft tissue signs. We come to the next is lid signs. So let's note it down and then we are going to the slides and we'll revise it again. When you say lid signs, first and foremost, the first important sign which appears is lid retraction. I just explained what it is. When the lid goes above its level. So this is called Dalrymple sign. Again, you have to know the term Dalrymple sign. So lid retraction, which is also called Dalrymple sign. Okay, why will there be lid retraction? Okay, so many of us can give this theory that there can be hyperthyroidism, which is causing the overaction of the Muller's muscle, which is supplied by sympathetic supply. I hope you all remember that. I have discussed earlier also. What are the two muscles which elevate your lid? One is LPS, supplied by third nerve, and second is Muller's, supplied by sympathetic. So if there is oversympathetic activity, there can be, yes, it could be a factor. But what about I told you just now that not every case is hyperthyroid. How will you explain then? Isn't it? So many patients are euthyroid, but many are hypothyroid. The better explanation here is, which has been taken, is because of the fibrosis of inferior rectus, which is a first muscle to be involved. There is a rebound overaction of LPS and superior rectus. So this is mainly due to, make life simple, overaction of all these lid signs actually are due to overaction of levator palpebral superioris. Okay, along with that superior rectus can also be involved, but mainly levator LPS. Just remember this one. All these lid signs are due to overaction of LPS. So the theory of oversympathetic activity can only fit in hyperthyroid patients. So that was lid retraction. What was the second sign? What is von Grafe sign? That is called lid lag. Do you all know what is lid lag? When you are looking up and you ask the patient to look down, normally, or when you look down, normally your lid will follow your eyeball. But if there is overaction of the LPS, it will fall behind. That is a lag. We call it von Grafe sign. So we are writing von, but we pronounce it as von. Okay? So we say von Grafe sign. So lid lag, lid retraction. Then there can be decreased frequency of blinking. Decreased frequency of blinking, which is called Stellwachs sign. Right? Decreased frequency of blinking is Stellwachs sign. Okay. So these are some of the lid signs that you will see in thyroid eye disease. And all of you, what is Mobius sign? That is difficulty in convergence. So that will be related to your myopathy. Right. Then we talk about, so you have learned all these signs in your surgery also when you're learning. Then after this, when you know these signs in this, I think, do you all remember that we learn all these features also with a very famous mnemonic? What is that? For clinical features, everybody remembers no specs. So can we quickly now see how it is fitting? So initially it starts with no sign, right? Then comes your O is only sign, and the only sign, the first is, please learn, lid retraction. No confusion, we will answer this. It's debatable, please answer lid retraction. Then comes your soft tissue involvement, which we have just learned about chemosis, Golgier signs and so on. Then we talk about what is P standing for is proptosis, right? And E is your extraocular muscle involvement, right? Here we have learned if there is a decreased convergence, what do you call that? We call it Mobius sign. We call it Mobius sign. And C stands for corneal involvement. We have already done this. And S is loss of sight. Why there will be loss of sight is of course due to optic nerve damage. And it's generally due to the more intraorbital pressure damaging the optic nerve. So due to optic neuropathy. Correct? So this is the pathogenesis and the clinical features, and of course muscle, we know how to manage that, soft tissue signs, how to manage that, we have just learned, right? So we were talking about lid signs, right? We didn't discuss this. Lid signs we are saying is due to overaction of LPS. So can you tell me what is the treatment for the lid signs? Let's understand something here. Suppose this is the eyeball. I'm just trying to explain you resection and recession. Just listen. So if this is the eyeball and this is the muscle attached, if the action of this muscle is less, you're going to cut it and stitch it. So fiber length decreases, and this is what is called resection. The action will improve. But suppose this is too much action, I don't want it. Then you can shift the insertion backwards. So going backwards is what is called recession. Okay? So that the effective action on the eyeball is less. Same is with lid muscles. So the basic is same, and what is the basic? We can just fit it here so that we remember always. What is the basic of any muscle surgery? In an overacting muscle, we are going to go for recession. Just economic recession hai na, वैसे this is muscle recession, right? Putting the insertion little backwards. And underacting, for the underacting muscle, we are going to go for resection. For underacting, we are going to do resection. Okay? So this is if this is the basis is clear to you, what is happening in thyroid eye disease? Overaction of LPS. So what should be the treatment? Treatment will be recession of LPS. Right? Easy? Yeah. And suppose a patient has a lot of problems and all the 3 surgeries have to be done, decompression, squint surgery, lid surgery. Then in that case, the sequence has to be Diesel, like this. Remember, Diesel. First, go for decompression. Why? When you do decompression, amount of squint will vary. When you do a squint surgery, the lid position will vary. So first decompression surgery, then comes your squint surgery, and then finally your lid surgery. Okay? So this should be the sequence. Are you familiar with what is called Rundle curve? I don't think they should ask you, it's more at the PG level. Just telling you here, it is the severity of this disease. One extra point here before we finish the topic. Severity of thyroid eye disease has one dynamic phase where it is increasing and then static. But static never goes back to the normal. Okay, so this becomes a static phase and this is your dynamic phase. Okay, so with time. This is how a course of thyroid eye disease will take place. Right, let's see the slides. Okay, yeah, one more sign for the lid. Yes, how did I miss that? Was staring look. What is that called? So first understand and then we'll look at the slide. So if the lid retraction is so much that the upper sclera is visible like this, it feels like the person is staring at you. And this is called Cocker's sign. So if you look in the slide, you will realize that in the right eye, this is your Cocker's sign. Please add this also if in your lid signs, please. Cocker's sign, and in your left eye, it is just touching the limbus. This is what is your, in this case, you are going to say lid retraction. That is your Dalrymple sign. So this is lid retraction. It should have covered 2 mm of the cornea. It should have covered 2 mm of the cornea. So this is your lid retraction and here it is Cocker's sign. What are you looking here? Enroth sign. Lot of chemosis in a thyroid patient. Congestion, chemosis. This is what is Enroth sign. This is your superior limbic keratoconjunctivitis. Right? Can we see this? This is your superior limbic keratoconjunctivitis. What did we learn? If this is the MRI of a thyroid myopathy, we are looking at the tendons are spared and only the belly of the muscle is involved. You can see a CT here. Again, this is the belly of the muscle which is involved. So looking at the CT, we are very sure that this is a thyroid myopathy. Rest your tendons are normal. We'll give the next heading as orbital cellulitis. Let us give the next heading, orbital cellulitis. How do you define orbital cellulitis? It is inflammation behind the orbital septum. Okay, so when I say inflammation behind orbital septum, you all should have a picture in your mind, where is the orbital septum? So apart from, of course, your section that you must have learned this very nicely when you were learning the section of the lid and all. But just understand from me. So if this is the lid and made up of the tarsal plate, correct? This is the bony margin. Wherever the tarsal plate is ending, yahan pe bhi yahan pe ending, and this is the bony, there's a space. This space is filled by a thick connective tissue, and this is what is orbital septum. So it's like a wall of the orbit. It is above also, below also. Okay? So do you understand like this? Any inflammation which is behind is what? So if I draw for you in a simple way, we'll draw this diagram, please. Suppose this is your lid. Now in my simple diagram, in my style. So this is the lid. This is the lid margin and these are the eyelashes coming out from the margin. So this becomes our tarsal plate. Done? Now, Similarly, on the lower side, this becomes your lid margin. This is the lower lid, right? So, and this is your tarsal plate. You get tarsal plate with the lid margin. These are the lashes. And if this is your supraorbital, so this one is your supraorbital margin. We can make it and understand for the lower lid also, as I just had drawn for you all. So this is the lid margin, this is the tarsal plate, and here is the infraorbital margin. We are saying that this small gap is filled by a thick connective tissue, and this is what is called orbital septum. I think now you have understood. And if this is the orbital septum, any inflammation in front, right the way I am writing, any inflammation which is in front of the septum, this is called preseptal cellulitis. It happens more frequently in children, preseptal cellulitis. And if it is behind the septum, now what we call it is orbital cellulitis. So this is why you are writing orbital cellulitis is inflammation behind the orbital septum. Clear it? So when I say preseptal, it's not very serious because it's not inside the orbital cavity. So preseptal may like any insect bite is happening, right? A mild trauma. So this all can lead to preseptal. Coming to orbital cellulitis. Why? Well, first of all, what can be the predisposing factors or causes why there can be your etiologies, why there will be cellulitis? Okay, so think like this and learn with me. Cellulitis will happen when some adjoining structures are involved with infection or inflammation. So one can be sinusitis, sinuses, paranasal sinuses. This exam question for you all, which sinusitis the chances of orbital cellulitis is maximum? We will answer ethmoidal. Okay, so for ethmoid sinusitis will has a high chance of orbital cellulitis. What is the second cause can be? Think yourself, dental. So any dental infection or inflammation, any dental cause can be the next cause, or it could be lacrimal sac inflammations, that is dacryocystitis, right? Then it could be any endogenous cause, right? So endogenous can be like any septicemia we are talking about. So endogenous cause like septicemia, or it could be your exogenous. When you say exogenous, means you are getting inflammation and infection inside the orbit, maybe due to some trauma, right? Exogenous cause. It can be fracture of the orbit, it could be any surgery in the orbit. So any fracture or surgery of orbit. This is your exogenous cause. Right? So these can be the causes where you can get orbital cellulitis. What is the most common etiological agent? This is asked in the exam. We will answer Staph aureus, number 1, and second you will answer is Streptococcus pyogenes. Of course, in children, it is mainly, more commonly, it is Haemophilus. Though after vaccinations, the chances have, the incidence have decreased a lot, but still, Haemophilus is important cause in children. Right, and this applies for both preseptal and orbital if they ask you, they have asked you, okay. So this applies for both preseptal and orbital cellulitis. Right, okay, then how will a patient of orbital cellulitis present? And okay, when we are talking about bacterial causes, what about fungal? Do we all remember this? The most common cause of orbital cellulitis, fungal causes mucormycosis. Very important topic for you all after COVID, right? Mucormycosis. We'll talk about it shortly. We talk about clinical features of orbital cellulitis. Clinical features, think yourself. Generally, the patient presents with unilateral presentation with painful proptosis. So, it's a unilateral and painful proptosis. Then write down restriction of eye movements due to proptosis. Restriction of eye movements, but it is not the nerves which are involved. It is not the nerve involvement which is causing the restriction of eye movement. Okay, it is because of proptosis, due to proptosis is important to understand here, okay. Because of this, there is the restriction of eye movement, right. What else you can get? Of course, slowly the vision is affected, especially When the orbital apex is going to be affected, it can drop down a lot. So decrease visual acuity. And of course, there will be congestion, conjunctival congestion, chemosis, periorbital edema, and so on. Okay, so lid edema, then conjunctival congestion and chemosis. Apart from that, the patient will have all the seismic features of fever, weakness, that is fever and malaise. Right, so this is how an orbital cellulitis is going to present. Okay. Then this is a very, very important question they have asked you. If we think about complications, how this orbital cellulitis can complicate into, do you realize there's of course, any orbital apex involvement means you have just learned what are the structures which are passing through supraorbital fissure, right? And inferior orbital fissure, optic foramen, this is what constitutes the orbital apex, right? So, what can be the complications? Of course, the complications could be, you can say, mainly optic neuropathy. That means there can be disc edema, there can be relative afferent pupillary defects, right? Then due to optic neuropathy, due to optic dysfunction, optic nerve dysfunction, neuropathy. Then especially in cases of mucormycosis, you may get central retinal artery occlusion or central retinal vein occlusion, especially in fungal cause like mucormycosis. Now comes the most important one. It can lead to spread to cavernous sinuses, leading to cavernous sinus thrombosis. So this has been your exam question, and what they have asked you here is that why is orbital cellulitis an emergency? So why generally a patient of orbital cellulitis we admit it immediately and start with the IV antibiotics. Why? Because of the risk of involving the cavernous sinus. Acha, when the patient has come to me, how do I know the cavernous sinus is involved or not? So we will revise the structure of cavernous sinus. If you remember, all the nerves 3, 4 and 5 are passing through the wall and 6th is passing through the center. We'll just talk about it. Just remember, it is the 6th nerve which is involved first in cavernous sinus, and so when my patient is presenting with a unilateral orbital cellulitis, I am going to check the abduction of the other eye, not the same eye, because that can be restricted due to proptosis. Check the one which is not proptosed. If there is any defective abduction means away from the nose caused by lateral rectus supplied by 6th nerve. So if the cavernous sinus thrombosis is happening, 6th nerve is involved, it will affect both eyes, okay? So abduction of the other eye is checked. Keep this in mind, right? So this is very important. We put a Q here. Why it is an ocular emergency? It is an ocular emergency because of the risk of cavernous sinus thrombosis. Because of the risk of cavernous sinus thrombosis. Right? Important question. Okay. So, yes, another complication, if you want to know more, it can even lead to abscess formation, intraorbital abscess formation or subperiosteal abscess formation. I think this is enough, and main important they have asked you is for cavernous sinus thrombosis. Right. So when I am trying to investigate this patient, of course, we know, so adjoining things have to be all checked if it is orbital cellulitis. So I can go for CT or MRI. We have to go for the orbit, for the sinuses and for the brain, right? So this is important. Treatment. How do you treat orbital cellulitis? Admit the patient, which is a big thing in ophtha, of course, and then start with IV antibiotics. This should have all the coverage. Aerobic, anaerobic, right? So the empirical therapy constitutes of, what do you give here, is ceftazidime, right? We give ceftazidime, we give vancomycin, and we will also go for metronidazole, right? Yeah. For fungal, of course, I'm just going to talk about when I take mucormycosis that we have to start with IV amphotericin B. So this is how we treat it. Now we talk about is, and of course prognosis is not that bad till it is only in orbital cellulitis. We may still be able to control it, but if it has gone to the cavernous sinus, now the things are bad. Prognosis becomes poor. Okay? Yeah. Talking about now mucormycosis, very, very important. I hope you all know this. During the COVID pandemic peak of the COVID pandemic, we all know that how the steroids were used and how this use of steroid has led to this opportunist infection. Otherwise, spores of mucormycosis is everywhere. Mucor is everywhere, isn't it? But these patients, when you're immunocompromised by taking so much of steroids, develop mucormycosis. We call it ROCM. What does ROCM stands for? It is rhino. These are the structures it involves: rhino or vital cerebral mucormycosis. This is how it can involve. So, infection is through inhalation of spores, which are, as I said, everywhere. Inhalation of the spores. And if you are immunocompromised, otherwise it will not do anything to you. But in immunocompromised patients, it can lead to this condition, that is ROCM. Right? So what it is causing, if for eye point of view, if I will take here, it is of course causing all the features of orbital cellulitis that you have studied will fit in. Number 1. Number 2, you have to also remember, why do you call it black fungus? It's not that the fungus is black, right? Why do we call it? Because it is mainly angioinvasive. Because it is angioinvasive, what it is doing is it is affecting the blood supply. And because it is causing ischemia of the tissue, because of the ischemia of tissue, it is going to lead to necrosis. And it is this necrosis which is seen as the black eschar. Right? So this is another point you have to understand. It is caused by, of course, mucor or rhizopus. Both can be the cause. Mucor or, write down, rhizopus. Rhizopus is considered more common. And once we know this, and of course we have to keep this in mind, the third important point, that the risk of serious complications like CRAO, CRVO, this is all more in cases of these infections. Now, talking about treatment, if it is a mucormycosis, we have to go for IV amphotericin B. Right? And apart from that, another IV that is a new drug we should know is posaconazole. That's it. This is about mucormycosis. Okay, we next talk about is cavernous sinus thrombosis. Okay, first see the slide. So here it is. This is a case of orbital cellulitis with uniocular. So look at the lid edema and how much of ecchymosis congestion is there. And when I'm looking into opening the eyes and seeing it, this is what it is. Lot of conjunctival edema and congestion is also seen. Right? And the eye is of course proptosed. Though you cannot comment, maybe it's just a swelling in this patient, but yes, it is proptosed. And this is a case of mucormycosis, where, why do you call it a black fungus? It is all because of the necrosis of the tissue. Talking about now cavernous sinus thrombosis, give the heading. Now before coming to the condition itself, we are going to revise the anatomy. This is a very important slide for you all. Quick revision here. So this is your pituitary gland, isn't it? And above that is optic chiasma. And here are the two cavernous sinuses which are connected, and therefore any thrombosis, that always this is a bilateral presentation. And what is important to understand here, the 3, 4 and 5. So this is 3, 4 and 5. 3, 4 and 5 are along the walls. This is your internal carotid artery, and this 1/6 is along into the body beside the internal carotid artery. They have asked you this question also, which nerve is inside the body of the sinus, which nerve is along the sides. Which is in the body? This is your 6th. We are going to draw it in a simple way. So it is the 6th nerve, and this is the reason the first sign of cavernous sinus thrombosis is 6th nerve palsy. Again an exam question. Okay, so now let us come back. We'll draw this very simply for ourselves here. These are the two cavernous sinuses. 3, 4 and 5 are along the walls. 6th is in the body of the sinus along with internal carotid artery. Right? Done? So this is the 6th nerve. First question, which is the nerve which is inside? So this is one question here, and second question is, what is the first sign of cavernous sinus thrombosis? First sign of cavernous sinus thrombosis, we will answer is 6th nerve palsy. It is 6th nerve palsy. Okay, so what are the features and how the patient will present? So first, of course, is sixth nerve palsy, defective abduction. Slowly, all 3, 4 and 6 will be involved. When all 3, 4 and 6 are involved, do you understand? This time, due to nerve involvement, there will be total restriction of eye movements. Okay, if you'll just think with me in this way, you will learn all the features. Then, of course, fifth is not going to be spared. Fifth is also involved, and when fifth is the trigeminal sensory supply, what do you start getting? Loss of blink reflex. Right? Corneal sensation is gone. No, so absent corneal sensation, loss of blink reflex. And because the third is gone, can you also think of that third is a efferent of light reflex, accommodation reflex. So absent light reflex, absent accommodation reflex. And of course, I just mentioned absent blink reflex. And proptosis, this time it is a bilateral condition. So we will say it is bilateral painful proptosis. Right? And because the pressures can be high, there will be bilateral papilledema. And very, very important, mastoid tenderness. Because emissory veins of mastoid drain into the sinus, we will answer here, we will write here mastoid tenderness. These are the features of cavernous sinus thrombosis. Okay. So, once we know this, talking about how will you manage, again the same way, we are starting with IV antibiotics. Exactly the same way that you have discussed for orbital cellulitis, both aerobic and anaerobic. And IV anti-inflammatory. In both cases, we should also write down IV anti-inflammatory. But the prognosis is very, very guarded, not very good. These are the points regarding cavernous sinus thrombosis. So here this is a case of bilateral proptosis, chemosis, congestion. So this is a case of cavernous sinus thrombosis. All the features that you've learned for orbital cellulitis will be there, but at this time in both eyes. Okay. Once we know this, we have to be familiar with this term. Let us learn here. What is superior orbital fissure syndrome? Next heading, all of you. Superior orbital fissure syndrome. Very, very simple. We just drew this diagram. You remember this now? You just learnt it. You just learnt with me, right? Yeah. So think yourself why I made this diagram so that you can think along with me. Whatever nerves are passing through the superior orbital fissure will be affected in superior orbital syndrome, which is nothing but any disease or inflammation which is happening at that place. So naturally it is at the orbital apex. You are going to, when all the nerves, that is third, 3, 4 and 6 are involved. So you will get ophthalmoplegia. Think yourself. Then of course pressures can be high and lead to proptosis. There will be loss of corneal sensation as well, right? And 3, 4, 6, 3, 4, 5, 6. So all these nerves are getting involved. Nasociliary is a branch of fifth nerve, isn't it? Yeah. When all these symptoms are associated with optic nerve involvement. Hope you're writing. This time I'm not writing with you all. So write down when it is associated with optic nerve involvement. I think this one is a better diagram now. Yeah. So this is what is called orbital apex syndrome. This is also important and asked. So all the features of superior orbital fissure syndrome with optic nerve involvement, that means here the optic nerve involved. Where is the optic nerve? Here in the optic foramen. So this is what is called apex syndrome, orbital apex syndrome. Then there has been one question on what is Tolosa-Hunt syndrome. So we will learn it's a granulomatous inflammation. I want you all to learn one line here, not more than that. What is Tolosa-Hunt? Granulomatous inflammation of cavernous sinus, superior orbital fissure or orbital apex. So write this first. What is Tolosa-Hunt? It is of course idiopathic and non-specific granulomatous inflammation. Idiopathic, non-specific granulomatous inflammation of cavernous sinuses, superior orbital fissure or orbital apex. Okay? Again, anything at the orbital apex will cause all these, will affect the nerve to leading to pupillary involvement, mild proptosis and some pain, periorbital and hemicranial pain. Nerve involvement can lead to diplopia. They will not ask you more than what it is, though. But you can still think yourself, if these structures are involved, what can be the presentation? So generally the typical presentation, say it is little milder form, that means the proptosis is not very significant and it's a vague type of periorbital pain, right? Remember that. And then we talk about investigation is CT and MRI, simple. Treatment, of course, it's an inflammation, so systemic steroids and immunosuppressive drugs. Note down, systemic steroids and immunosuppressive drugs. Right. Next we talk about is lacrimal gland tumor. Our next heading will be lacrimal gland tumor. So lacrimal gland, I hope you all remember where it is, outer upper quadrant. So any tumor in the lacrimal gland is going to push the eye down and in. So it is going to lead to non-axial proptosis, right? So where is the shift? Down and nasal dystopia. The shift is called, so down and nasal dystopia. Right? Simple thought. Okay, now we have to learn the names of the different types of lacrimal gland tumors. Okay, so what are the different types of lacrimal gland tumor? We can divide it as, so one way of dividing is benign and malignant, right? Or you can also divide it as, it can be epithelial or non-epithelial. Epithelial or non-epithelial. And this can be further divided as benign and malignant. Here again, benign and malignant. So benign epithelial is what is asked to you. This is your pleomorphic adenoma. So pleomorphic adenoma is also called benign mixed tumor. Benign mixed tumor. Talking about the malignant epithelial, if this becomes, what are the different malignancies? We will learn all. First, if this becomes malignant, we will call it pleomorphic. Just write the names, adenocarcinoma. Second is mucoepidermoid. And third is adenoid cystic. Adenoid cystic. Coming to non-epithelial, benign is generally, we will say, inflammatory. And malignant we have to learn is lymphoma. Most commonly, it is lymphoma. Right? Now, a few questions that we have to work upon. Most common lacrimal gland tumor. This is your exam question and it's a repeated question. Most common lacrimal gland tumor. Overall, we will always answer pleomorphic adenoma. Whenever this is asked like this, most common lacrimal gland tumor, we will answer pleomorphic adenoma. And most common malignant tumor or malignancy, again, even if it is overall, we should answer adenoid cystic. If they are specifying non-epithelial, then you can answer lymphoma. Otherwise, you will just answer for overall also adenoid cystic. So this is most common malignancy. And second point here, this is the most dangerous tumor as well. Why do we consider adenoid cystic as most dangerous? Because it spreads very fast due to perineural invasion. Okay, so due to the perineural invasion, it spreads very fast. Okay, let's have a look here. So this is the case of pleomorphic adenoma, right? So it is generally, if you look here, fullness in the lids that it is causing, and this is the tumor here. What is very important, it is smooth, so just remember, it's a non-tender and smooth and firm mass which is felt in the lacrimal gland fossa, leading to inferonasal dystopia. We have discussed all this. So now it is non-tender, very important point, and firm. It mainly involves the orbital lobe of the, so lacrimal gland is divided by the LPS muscle into palpebral part and orbital part. So it is mainly involves, note down all of you, orbital lobe, okay, orbital part of the lacrimal gland, orbital part, right, and it can also lead to S-shaped deformity of the lid. These are few more points to remember. So this is your pleomorphic adenoma. It's the most common overall. You have to know a little more about it. And whenever we are dealing with it, never go for incisional biopsy. We always do excisional biopsy, excise it. So treatment, you write it here, is always recommended is, of course, remove the tumor for always. So you should know, avoid incisional, go for excisional biopsy. Right? That was about this tumor. Again, we are looking at the same lacrimal gland tumor here. Now, which tumor is this one? Come to this one. It is a sac tumor. Can you see this? Naturally, this time the dystopia is, what was this dystopia here? Down and nasally, infero-nasal. This time it is supero-temporal. So, a sac tumor can lead to supero-temporal dystopia. Isn't it? What is the most common malignant and what is the most common benign of lacrimal sac tumor? So, for benign, we are going to learn papilloma. Malignant, learn with me, squamous cell carcinoma. If they ask you, suppose if they have not even asked you, they can ask you anytime. Squamous cell carcinoma. Right, all of you? So that was lacrimal gland tumor. Our next heading will be pulsating proptosis. So when the proptose dye is showing pulsations, we will call it pulsating proptosis. Now what they will ask you in exam are causes. What is the etiology? First, most important is carotico-cavernous fistula. You just saw the cavernous sinus anatomy and all, which I just showed you the slide. So, then internal carotid is passing through it. Any fistula between the cavernous sinus and the carotid artery. This is your CC fistula. In short, we write it as CC fistula. What is the second? Second that we will learn is, think yourself, what can be the other cause where you can get a pulsation in a proptose dye? Now this can happen if the intracerebral pulsations are transmitted to the eye. So our next cause could be fracture roof of orbit. And the third cause could be when the roof is not formed at all. Right, in NF1, right? So, in these situations, it is the intracranial pulsations which are transferred to the eye, which are transmitted to the eyeball leading to pulsating proptosis. Okay? Now, they have asked you one more thing. Which is the most common cause of pulsating proptosis? We will answer CC fistula. Okay, so most common cause if they ask you, we will answer carotico-cavernous fistula. Okay, now we next talk about is carotico-cavernous fistula or CC fistula. So, it is one of the very important causes of painful proptosis. So, fistula can be divided as direct or indirect. Few important points, quick points here. Direct or indirect. When we say direct, it means it is between the carotid artery and cavernous sinus. Artery and cavernous sinus, right? This is direct. Majority of the times the etiology is trauma. Okay, so 75% of the cases are due to trauma. Whereas when you say indirect, it is mainly the meningeal branches. So it is the meningeal branches of internal and external carotid artery with the cavernous sinus. Of internal carotid artery or external carotid artery with cavernous sinuses. We call this dural shunts. Correct? Now, talking about the direct, we learn as a clinical feature if we talk about that it is mainly, we learn a triad here. And the triad is number 1, pulsating proptosis. Second is your chemosis, severe chemosis. And third is your whooshing sound in the head. The patient can hear some whooshing sound in the head. Right? Now, apart from that, think yourself. If there is what is exactly happening when there is a fistula formation? There is increased pressure in the cavernous sinuses. Isn't it? So, apart from this, 1, 2, 3, which is a triad, any increased pressure in cavernous sinuses, do you realize can lead to increased episcleral pressure? because all the venous system, blood from the vortex vein and all through the superior and inferior ophthalmic vein drains into the cavernous sinus. If the pressure in the cavernous sinus is more, so what is happening? Episcleral pressure will increase, which will lead to glaucoma. Keep thinking along with me. Again, if there is more pressure, it is also causing venous stasis, and this venous stasis can later lead to arterial stasis. Right? When there is a venous stasis, it affects the retina, leading to venous stasis retinopathy. Right? So, venous stasis leading to arterial stasis. What are the things it is leading to? Number one, retinopathy. Then there can be ischemia in the anterior segment. Right? So, we can learn anterior segment ischemia. Think yourself, and when you think and learn, it is easier. And all the nerves that are passing through the cavernous sinus can be affected because their blood supply is affected. Right? So, third that you can write down, the third in cavernous sinus, when there is increased pressure, the third point in increased pressure of cavernous sinus is decreased blood supply to the nerves in the cavernous sinus. So, 3, 4, 5, 6. So, there is a decreased blood supply here, and it can affect these nerve functions. Right? So, all this will be 3, 4, 5, 6 are affected. And along with that, do you also remember the sympathetic vein is traveling through the internal carotid? So, you may also get postganglionic Horner's. We have learnt in neuro of the postganglionic Horner's syndrome. Okay? So, if this way we are learning and thinking, we learn better. And of course, when there is a congestion and stasis, there can be conjunctival redness and the typical appearance of dilated tortuous conjunctival blood vessels, which is called, we call it corkscrew vessels. Corkscrew conjunctival vessels. Okay? So, along with the venous retinopathy and venous stasis retinopathy, you are also getting this stasis is leading to dilatation of. Now, let's have a look at these vessels and let's have a look at the signs. So, this is a bilateral caroticocavernous fistula, and you can see here the pulsating proptosis, the chemosis that we talked about. All the things are so obvious. Congestion, right? This is what is the dilated and tortuous corkscrew vessels. Right? So, this is your corkscrew vessels. And this is also finding for indirect. So, if you may think, okay, this was direct, what about the indirect? All the features are the same. Of course, don't go for the triad exactly. You may not get the whooshing sound, but all other features that you have learned are same. Okay? But in a milder form, in a much milder form. Just learn like this. That is enough. Okay, so when you talk about the investigation in a CC fistula, when you're going to do a CT or MRI, what you get is a dilated superior ophthalmic vein. Right? The vein is dilated. There are other investigations and angiographies that you can go for. I'm not going to detail, you have learning it in the medicine part also. So, coming to the treatment, again the treatment in cases of indirect, it generally resolves spontaneously. Whereas in direct, you may go for either coil embolism or balloon tamponade. Right? For the direct ones, we may have to go for a balloon tamponade or coil embolization. Right? And write down for indirect, it generally resolves spontaneously, resolves by its own, resolves spontaneously. Okay, after pulsating proptosis, we are going to start with intermittent proptosis. So, when you say intermittent, what is the difference? In pulsating proptosis, the proptosis is continuous and that's there are pulsations, right? In case of your CC fistula, there will be a brew and thrill as well. But when I say intermittent, sometimes it is there, sometimes it is not. It changes with the head posture. Suppose the patient says that at one position, I feel fine, but when I lie laterally, supine I am okay. When I lie laterally, suddenly I feel my eyes coming out. What is happening? Why it is changing with the head position? We are talking about orbital varices, the only cause of intermittent proptosis. Okay, one cause of intermittent proptosis, which makes some sense. Why? Because at one position the varices are full, other it is not. So it is orbital varices. See, I have made a double Q, all of you. So orbital varices or varicose veins in the orbit, because these are generally thin-walled and distensible low flow veins. Okay, they are distensible and low flow veins. Because they are mainly connected to the venous system, this is the reason that it communicates with normal venous system and therefore increase with Valsalva procedure, cuffing, change of head posture and so on. Okay, so increases with Valsalva, cuffing, change of head posture, head position. Got it? So this is the main point regarding intermittent proptosis. What is the cause is what they have asked you till yet. Let's have a look. So if you look here in this, when you're looking at the CT, in this case, this mass is your varicose veins, but when in a resting condition it is like this, and this is post contrast and doing a Valsalva, it increases up to this. So have a look. These are orbital varices. As I said, these are thin-walled distensible veins. It can calcify and lead to phleboliths formation. Okay, one more point. Stone formation after calcification. Right? So when I am doing a CT, what do you see? So this is an irregular mass that you see here, isn't it? Ill-defined mass. You can say it looks like an ill-defined mass on CT scan. How do you, of course, treat it? You have to remove it, but surgical excision can not be a good option because it's very friable. As well as, so what do you do if you don't want to go for that? You can go for carbon dioxide ablation. So if I talk about the treatment options, surgical excision is little difficult. Go for either carbon dioxide laser ablation, right? Or we can go for is endovascular embolization. So surgical excision, just mention here all of you, it is difficult because of, as it is friable, it is very friable. So that was about intermittent proptosis, and that is your varicose veins or orbital varix. Right. A few more questions that have been asked in your exam and you should be knowing it. These are all double Qs. They have asked you what is the most common primary intraocular malignancy, primary malignant tumor so we are talking first of intraocular primary malignant. Okay, so in children, of course, we all know we have to answer retinoblastoma. We will learn retinoblastoma in the retina chapter. And for adults, you are going to learn is, these are all Qs, okay? Choroidal malignant melanoma. Malignant melanoma. Now coming to the next question, if I ask you, again double Q, most common this time orbital malignant, primary malignant tumor. For children, write like this, and adults. So for children, we are going to answer is rhabdomyosarcoma. Okay, rhabdomyosarcoma. And for adults, it is lymphoma. So your next question has been in the exam, which lymphoma? Non-Hodgkin's lymphoma. Which cell type? B cell type. So these are all different year questions this way. Okay. One more thing. If I ask you about intraorbital but benign. So most common intraorbital So they may not say benign. They will just say intraorbital tumor. It means benign unless and until we mention malignancy. Okay. So this was your question like this. The language of the question was most common intraorbital tumor of adults. So most common intraorbital tumor, automatically we are talking of benign. For adults has been repeatedly asked, and the answer here is cavernous hemangioma. Okay. And for children, we are going to answer. See, earlier we were answering previous years dermoid cyst, but we are now going to change it in the latest edition. It is saying capillary hemangioma. So dermoid cyst will come as a second number. First we will answer is capillary hemangioma. If this is not given, then we can answer dermoid cyst. Okay. Okay. A few points about cavernous hemangioma here. Once you know these questions, cavernous hemangioma, unlike other hemangiomas, very important, it is encapsulated. Okay. So it is first of all intraconal in location. This was also important points. Write down intraconal within the muscle cone, as you can see here, right? It is encapsulated and hence easily resected. Because it is encapsulated, it is easily resected. And this is more common in middle-aged females. Middle-aged females. And because it is intraconal, it is going to lead to axial proptosis. Next important point, axial proptosis. Have a look. So this is a case of cavernous hemangioma. Can you see the fullness in this area, which is showing there is a bulge, and it is causing axial proptosis. So how do you treat a cavernous hemangioma? You can just excise it. Excision is very easy. We have just talked about it. Bilateral laparotomy. You can just excise the tumor. These are the few lines and important points about cavernous hemangioma. Now, what is this case? This is your rhabdomyosarcoma. So, rhabdomyosarcoma, few points here. What are the important points you have to know? Of course, it's the most common malignant intraorbital tumor in children. It is arising from the connective tissue. So, it's a connective tissue tumor, but it has a capacity to differentiate as muscle cells. So, it's a connective tissue tumor which differentiates as muscle. So, this is mainly the presentation in children of less than 16 years. So, 90% of the cases are seen in children of less than 16 years. And then just be very, very familiar with two more things. Pathologically, how do you classify? It's a very, very known thing. We will know the name. So, pathologically, you can classify the rhabdomyosarcoma as embryonal. Embryonal is most common, but it is undifferentiated. Not good, right? Then second is your alveolar. Alveolar is also very aggressive. Then third you can note down is your pleomorphic, and fourth is, you will say, boteroid. Just know the names, no more details I want you, just know the names. So this is how we classify, and on treatment part, let us understand here, we generally move towards chemo and radiotherapy. We are generally not going for surgery. So this is another important point. We avoid exenteration and want to treat it with, because it's quite responsive with chemo and radio. Just note down the treatment will mainly be chemotherapy and radiotherapy, or either only chemo or combination of chemotherapy and radiotherapy. Right? So that is about rhabdomyosarcoma. Which are the drugs and chemo? If you want to write it, write it. Vincristine and actinomycin D. Please note down vincristine, actinomycin D. Now, what are you looking at now here? A small child with, I see a bulge, which is almost at the suture line. This is a case of dermoid cyst. We are talking about dermoid cyst. So, what is a dermoid cyst? Dermoid cyst is a choristoma. We all know what is choristoma, which means a normal tissue is at the abnormal place. So it is mainly normal tissue at abnormal place. So this is mainly along the embryonic fissures. Okay? This is due to sequestration of embryonic epithelial cells and it is along embryonic fissure. I think you all know it better than even me, all the details, right? Most commonly here you will see is superotemporally. Just learn these one or two more points. Most commonly superotemporally, that is a frontozygomatic suture. Right? So these are some points regarding. We won't go into too much detail, not needed. I told you if they ask you most common benign intraorbital in children, first is capillary hemangioma, second will be this one. That is dermoid cyst. Okay, so remember it is most commonly superotemporal. Again, treatment would be, in CT you will see it is a well circumcised lesion and in total we remove we want to remove it in toto. We don't want the keratin to spill and cause inflammation. So generally surgical excision in toto. Done? That was your dermoid cyst. We come to the next one. Now what are you looking at here? Most common benign intraorbital tumor of children. We are talking about capillary hemangioma. What are the points to remember in capillary hemangioma? You just learned with me that in cavernous hemangioma it is more common in middle-aged females. Now you learn here, this is again more common in females but in children, female children. Point number 1. Okay. So if you look here, they are ill-defined anastomosing vascular channels. So it is not defined like cavernous hemangioma, right? So it is ill-defined. That's another difference. We also call it strawberry nevus. We also call it strawberry nevus. Right? Okay. So, capillary hemangioma, because it is so friable, and of course, if it is at this position, which type of proptosis it is causing? Again, even in dermoid cysts, what was the proptosis? We will say it is non-axial proptosis, right? So it is causing a non-axial proptosis. How do you treat it? So one option of treatment can be your oral propranolol. Apart from that, again, it is very difficult for a surgical excision to be done cleanly. So you can again go for those options like carbon dioxide laser excision. Or sometimes if you don't want to go to the excision part, you can just give intralesional steroids. Okay, so intralesional triamcinolone acetate. Intralesional triamcinolone acetate. Right. Then we talk about, so these are few points about capillary hemangioma. How is it different from Sturge-Weber syndrome? Sturge-Weber syndrome is a phacomatosis, isn't it? Now what is Sturge-Weber? It is a triad, learn with me, of one, what do you see here? This is also capillary hemangioma. We call this nevus flammeus. Remember this? It is called nevus flammeus. How is it different from capillary? It does not blanch. Capillary hemangiomas may blanch. This does not blanch. And if you see this in patient, we have to see it may be a part of Sturge-Weber, which is a triad of, one is this nevus flammeus, then the same capillary hemangioma, I am making it very simple, capillary hemangioma in the brain, and third part of the triad is glaucoma. Again, glaucoma is mainly due to increased episcleral pressures. Right? So, we have to differentiate, and what you should know what is Sturge-Weber. It is a triad of capillary hemangioma on the face, which is called nevus flammeus. Second, it is glaucoma and capillary hemangioma in the brain. Okay? That was about Sturge-Weber. Okay, so our next heading would be optic nerve tumors. We will talk about first is optic nerve meningiomas. What are the points to remember? Very important. This is a tumor from the meningoepithelial cells. Okay, this is tumor from meningoepithelial cells from which layer? Arachnoid layer. Okay, and majority of the times, 2/3 of the cases, it is actually secondary. That is, the primary is intracranial tumor. So 2/3 of the cases, the tumor is secondary tumor and the primary is in the extension from the, so it's actually an extension from intracranial tumor. Intracranial meningioma. Okay, and 1/3 is going to arise independently. Now this next point is mainly seen in middle-aged females. Okay, middle-aged females. Another important point which is an exam question, it is more common in patients with neurofibromatosis type 2. Neurofibromatosis type 2. Right? So, talking about, if I talk about your clinical features, we learn it with a triad which is called Hyoth-Spencer triad. It says that it will present as, so you have to think yourself, it is an optic nerve sheath tumor. So optic nerve sheath tumor, it will first affect the optic nerve function, isn't it? So the triad says it is progressive visual loss, optic atrophy and opticociliary shunt. I'll just talk about opticociliary shunt. What is very important to understand that proptosis will be a late feature. Okay, proptosis will happen, but later on proptosis, but it is presenting late. What did we learn in your neuro-ophtho also? Which is the muscle? Which muscle fiber is attached to the optic nerve sheath? Superior rectus. So what you can get here is a restricted eye movement. And which restricted? Which movement? Up gaze. Due to superior rectus fibers being involved. And we may also get, because of this, gaze evoked amaurosis fugax. Okay, transient loss of vision, which can be gaze-evoked amaurosis fugax. Also, there could be a sphenoid bone hyperostosis will lead to temporal fossa fullness. Temporal fossa fullness, which can happen due to hyperostosis of sphenoid bone. So, these are some of the important points related to meningiomas that we have to know, right? Okay. Talking about pathologically, pathology में very important are Samoma bodies. Okay, so what are Samoma bodies? Let's see the slide only. These are laminated calcified bodies, right? So these laminated calcified structures, this is what is called Samoma bodies. It is typical of this condition, we should know this. And what did we just said? Opticociliary shunt. So it is actually, these are the blood vessels between the ciliary system and your retinal blood vessels, right? And you see near the disc, due to the high pressures, it can also be seen like in central retinal vein occlusions. So what you see, this opens up and this is what is called opticociliary shunt. So what I am trying to say, it is not a newly formed. These vessels are there, they just open up. Okay, anastomosis. This is an anastomotic system between the ciliary system and retina. This is what is opticociliary shunt, which is also exam question, a feature of meningiomas in particular. And what do you see? Then write down investigation. Investigation, we will, if I do an MRI, what do I get? So in case of coronal section, this is what is called bull's eye appearance. Okay, we will learn bullseye maculopathy in retina. Here we are learning bull's eye appearance. And in case of the axial section, axial view, what we see is a tramp track appearance. So this is the tramp track appearance. So this is the, if you look at the other side and look at this side. So there is a tumor here which is giving a tramp track appearance, already written. Just know the terms. Now, very important, as in the exam, what you get in a CT scan is tubular enlargement. This was MRI. Hope you have written. Second, write down CT scan finding is tubular enlargement of optic nerve. So, this CT scan finding is tubular enlargement of optic nerve, and along with that, there is calcification. We may find calcification. And how are you going to treat it? We generally observe, because whenever you are going to try to remove it, naturally the optic nerve will be damaged. So treatment write down is observation, and if this is not working, we go for surgery. Observation, if it is not working, then we go for surgery. Okay, we come to the next optic nerve tumor that we will learn is optic nerve glioma. Again, very important. Optic nerve glioma. Questions are asked. So when you say optic nerve glioma, what are glial cells? Glial cells, we all know, are all the non-neuronal cells of the nervous system. You may note down are glial cells. We all know this anyway. So like astrocytes, oligodendrocytes, which forms the myelin sheath, then neuroglial, microglial, ependymal, all these are glial cells. So when I say optic nerve glioma, it is a tumor of what? It is a tumor of astrocytes. It's an astrocytoma. In contrast to meningioma, remember this is a tumor of childhood and again more common in females. Okay? This tumor is more common in patients of NF1, neurofibromatosis type 1. This is exam question. Please make a cue there. Right. So how will this patient present? Again, it is the same thing because it is an optic nerve tumor. First thing will be all the 5 signs of optic nerve disease, right? So decreased visual acuity, visual field defect, decreased brightness, decreased color, all those signs that you have learned in Neuro-Ophtha will be presenting, and later when the tumor size is increasing. So later when the tumor size increases, it pushes the eye out, leading to proptosis. So again, proptosis becomes a late feature, right? Yeah. Then they have asked you about which is the most common, for pathology point of view, which is the most common pathological type. So most common pathological type we are going to write pilocytic astrocytoma. It is pilocytic astrocytoma. Okay. So when you say pilocytic astrocytoma, these are spindle-shaped cells. Hair-like. Pilocytic means hair-like. So these are spindle-shaped cells. Okay. Then we talk about how will you investigate. If you do a CT scan or MRI, what you are going to get is, let's have a look as well, fusiform enlargement of optic nerve. Fusiform enlargement of optic nerve. So this is the fusiform. Can you see this? This is the fusiform enlargement of the optic nerve. And treatment, again, if you are going to remove this, you are going to damage the nerve, and it's a very slow growing. Please note this down as well. It's a very slow growing and generally unilateral in presentation. Okay. So because it is slow growing and it is generally unilateral in presentation, so therefore treatment, initially there will observation and later you can go for excision. If nothing works, then you will do the surgery. Otherwise, why observation? Because you want to preserve the nerve as long as it is possible. Right? So these are the 2 important optic nerve tumors you should know. Next, we are going to learn a few points regarding, we have been talking about NF1 and NF2. Let's talk about the features of NF1 and NF2. So first, how do we learn the features of NF1? This is a very interesting mnemonic, ocular. Okay, when you say ocular, O stands for orbit, C is cornea, uvea, lid, angle, retina. Okay, so this is OCULAR. If we learn like this, it becomes easy to learn. We are talking about NF1. So if you want, you can note it like this. Orbit, we have just learned optic nerve glioma. Cornea, we have learned that there is thickening of the corneal nerves leading to prominent corneal nerves. Why prominent? Thickening of the nerves. Then uvea, leash nodules. These are the leash nodules. Hyperpigmented, hyperchromic nodules. Okay, this is the most common ocular feature if they ask you. Then of course lid, there can be neurofibroma in the lid, which also leads to, so these are the leash nodules, and this leads to neurofibroma in the lid is leading to S-shaped deformity. Okay, we learned S-shaped deformity for lacrimal gland also, but we'll first prefer this. So for neurofibroma, you typically get an S-shaped deformity of the lid. Okay, that was L. Right? Angle, you can get glaucoma and angle anomaly leading to glaucoma, and retina, what you get is choroidal nevus and astrocytoma. Choroidal nevus and astrocytoma. This was about your NF1. NF2 पे आते हैं. NF2, they have asked you one question, most common ocular feature, posterior subcapsular cataract, right? So it is presenile also, that is before, actually presenile ideally should be before 50 years and so, but whatever. So here it is presenting before 30 years. Apart from that, what else? We have also learned about that it is in NF2 patients, meningiomas are more common, so this is easy to learn, right? Then, of course, diagnostic criteria is very important. You should keep in mind bilateral acoustic neuroma, positive family history, and the ocular features, right? Please don't forget this. And in ocular features, PSC is very important to learn. Meningioma, you already know. Rest you want to learn, you learn. If you don't want to learn, it's okay from my side. Right. Now our next heading after this is blowout fractures. Let's write the points here. Can you see here? This patient has got a blunt trauma in the right eye, because of which, what are the things and features we can see here? So first of all, what are blowout fractures? Number 1 point, fracture floor due to blunt trauma. I have already talked about that the weakest part is posteromedial. And why there is a fracture of the floor? Write down the mechanism is buckling effect. Due to the, so when there is a blunt trauma, there is a buckling effect in the floor which leads to its fracture. Okay. What further we will write here, that any blowout fracture can be pure or impure. Pure we say when infraorbital rim is not involved. So when rim not involved, then we call it pure. Impure means infraorbital rim is involved. Infraorbital rim is involved. Then this is your impure. Okay. Now we talk about features. Think yourself, we are going to learn in myself, outside toe in. If there is a blunt trauma, first black eye, isn't it? We call it periocular ecchymosis. So first would be periocular ecchymosis. That is also called black eye. Now I want to point out here, this is not panda eye or raccoon eyes. That is seen in fracture base of skull, right? Roof fractures, not in floor fractures. Secondly, what you will see, think again, decreased sensation on the affected cheek, the side, of course, any side wherever the trauma is. So decreased sensation on the cheek. Okay. Why it is happening? This is due to damage to infraorbital nerve. Damage to the infraorbital nerve. Now, how will I know how will I know whether the sensation is less or not? We ask the patient to close the eye, we are touching the cheek with the cotton. He has to count whenever there is a touch. So it can be on this cheek or this cheek. So the affected side, you see, he starts missing the count. Okay, so this is the way we will judge whether the sensation is good or not. Then what else you are going to get? Just you saw in that clinical slide, I had gone inside. This is called enophthalmos. So in Horner's you had learned was apparent enophthalmos. This is true enophthalmos. And of course there can be diplopia, right? Now why are you getting a diplopia? Diplopia will happen because of few reasons, isn't it? So first important reason is there is edema and hemorrhage can be one cause which is restricting the motility. Second, it could be just entrapment of the muscle at the fracture site. So which muscles can be entrapped on the floor fracture? The inferior ones, inferior rectus, inferior oblique. So entrapment of muscle, which muscle? Common sense, it can be inferior rectus or inferior oblique. Or it could be actual injury, direct muscle injury. So any of these things will lead to diplopia. Any other feature we want to mention here? Which is the weakest wall of the orbit? It is the medial, so that can always be affected. If medial wall is affected, the sinuses will open. What are you going to get is subcutaneous emphysema. So what we are going to get is a subcutaneous emphysema. Okay, but only please note it down, if medial wall is affected, you are going to get this. And due to the pull of the muscle, very important point, it can actually incite a oculocardiac reflex. Now when you say oculocardiac reflex, we will be discussing in Squint chapter also how the pull on the muscle can lead to bradycardia and sometimes cardiac arrest through the vagus nerve. Right? So the afferent is from the trigeminal and efferent from the vagus. This is your oculocardiac reflex. So this can also happen in blowout fractures if there is a pull in the muscle. So it can incite an oculocardiac reflex. So that becomes very dangerous, of course. Right? So these are the features. We come to investigation. Of course, we can go CT scan, or you can even do an X-ray. PNS view can help us to see the floor. So whatever you do, either of this, what you get, let's understand that. We are getting, make this diagram. This is the floor fracture. Below this is what? Maxillary sinus. The sinus is filled with air, so it will be black. Right? So against this black background, I am getting an opacity like this. This is what is called, repeated question of exam, teardrop sign. So this is what is teardrop sign. So what is teardrop sign? Which is an opacity against the black background of maxillary sinus. Here it is. So this is the blowout fracture within ophthalmos. There is ecchymosis, right? And this is what is teardrop sign we're talking about. Right? So this white opacity against the, which is again due to hemorrhage edema, we get this opacity against the black background of maxillary sinus. So once we know this, we talk about treatment part. So treatment, of course, we start with the medical treatment with antibiotics and anti-inflammatories. But after 10 days of all this therapy, if there is no improvement in diplopia and no improvement in inophthalmos. Now, what does this indicate? This indicates muscle entrapment. And that means if the muscle is entrapped, then we have to go for surgery. So this has been exam question for you. What is the indication of surgery in a blowout fracture? So if they ask you like this, first of course is entrapment of muscle. If we doubt, we have to, the option is surgery. What can be the other indications of surgery? One is entrapment. Other indications can be if inophthalmos is more than 2 millimeters or half of the floor fracture, big fracture of the floor, half of the floor has a fracture. So in all these conditions, we will go for surgery. But what has been asked from you has been no improvement of diplopia, no improvement of inophthalmos. Even in spite of 10 days of therapy, it indicates muscle entrapment. Which muscle? Either inferior rectus or inferior oblique. Okay. So this is about how you treat a blowout. And what is the surgery all about? You're going to dislodge the muscle and do a microplating. Okay, and help the, otherwise any fracture heals itself by itself. If there is improvement of inophthalmos and diplopia, we don't need to do anything. Only medical therapy is enough. But if nothing is improving, it means entrapment, then you have to go for surgery. We come to the last heading of this chapter, and that is surgeries to remove the eye. What are the surgeries for eye removal? Okay, we first start with enucleation. It has been your exam question. What is enucleation? Nucleus is eyeball. So all the muscle attachments on the eyeball you cut and remove the whole eyeball with maximum part of optic nerve. Okay, make the diagram, you'll never forget. So we will learn like this. We are not only removing the whole eyeball, we are also removing the maximum part of the optic nerve. This is what is enucleation. Okay. I am writing the whole thing because it was your exam question. Right. So, talking about another important thing about enucleation, it is contraindicated in panophthalmitis. We will not do in panophthalmitis. Right? Because it can, the infection can spread to the orbit and then further to the brain. So, due to risk of spread of the infection. Okay, so why do you want to go for enucleation? What are the indications? So indications, just remember any painful blind eye. Painful blind eye, very important, right? Then it could be intraocular tumors. If it is only intraocular and has not spread to the orbit, so intraocular tumors if you want to get rid of, like for example retinoblastoma, choroidal melanoma, so we are going to go for this surgery. And thirdly, we can also learn about, it could be like phthisis bulbi, sometimes deformities like microphthalmos you want to treat, but generally in these indications like phthisis bulbi, painful blind eye, we are doing enucleation. Okay, now once you have removed the eyeball, do you realize you have the whole space is vacant in the orbit? Now if the whole space is vacant, if I leave it, it will be filling with granulation tissue. We don't want that. So generally immediately after the surgery or maybe in the same sitting or within 10 days, I am going to put a orbital implant. This is just like creating a base on which later I am going to put a prosthesis. So I will, after putting the orbital implant, I will wait for 4 to 6 weeks and then I am going to put the prosthesis, which is looking like exactly like an eye, and you stitch the muscles on it, it also moves like an eye a little, right? So this is important. First thing they have asked you enucleation, when to do orbital implant. This is a cue. When to put an orbital implant and when to put a prosthetic eye. This is also important. So answer is after 4 to 6 weeks after it has healed. And orbital implants can be either put in the same sitting, especially the ones which are made up of hydroxyapatite. They can be put in the same sitting or within 10 days. Clear, right? So this was about your enucleation and the points to remember. Now, what is exenteration? If the tumor, either a tumor is in the orbit, right? So any eyelid malignancy or orbit malignancy, this can be one indication. Or any orbital malignancy. Or it could be mucormycosis, right? So in any malignancy or in mucormycosis, I cannot take a risk of this spreading to the brain. So what I am doing in exenteration, we again make a diagram to understand. Exenteration is, write down on the diagram please, removal of all orbital contents. Right? Okay? Second, write down periosteum is also stripped. On the diagram please, you will learn better. Third, write down lids are cut. This is what is exenteration, and lids are cut. This is total exenteration. Right? So this total exenteration is removing everything so that the malignancy or mucormycosis is not going to the brain. And of course, after this, we can just refer to for grafting and making it cosmetically little better, isn't it? Or sometimes, so either we go for some grafting, refer to the plastic surgeons for it, and making it cosmetically better, or we can use some spectacle prosthesis, right? Because you can't do much on this. The patient can wear a spectacle in which this prosthesis, spectacle prosthesis, where artificial eye type of thing can be seen, or just remember this much at your level, unnecessary it will complicate, right? So this is about your exenteration, after which we are doing either grafting or spectacle prosthesis. Now I want you to be familiar with one or two terms here. What do you mean by partial exenteration? This was total exenteration. When do we call it partial exenteration? When we do not cut the lids. So let us also learn partial exenteration is when lids are preserved and apex is preserved, orbital apex is preserved. Mainly, let's make life simple. Lids are preserved, it becomes partial. And when will you call it extended? Okay, when are we going to call it extended? Naturally, it will be more than total. So, extended exenteration, you will learn total, you will do whatever you have done with bone is also removed. Right? Then it becomes extended. And of course, radical dissection, we all know what it is. Right? So, this was about exenteration. Now, what is evisceration? The third one. What is evisceration? All of you. Viscera ko nikala. You're removing the viscera means what are you doing? Cut the cornea and the limbus. Remove it, throw it away. Scoop out everything. You're left with sclera. Okay? Stitch it. This is evisceration. But if your sclera is also very much infected or inflamed, cut maximum part of the sclera and leave only frill behind. Then we call it frill excision. Did you get me? What did I say? Evisceration is cut the, so okay, let's make a diagram and write here. We have cut the cornea at the limbus. At limbus, write down. Scoop out everything and then stitch the sclera. This is evisceration. Now, if I am removing maximum part of the sclera and only leaving a small frill behind, because the sclera is very inflamed, we call it frill excision. So, do you realize frill excision is a variant of evisceration, and the indication for frill excision is panophthalmitis. When sclera is also inflamed, in panophthalmitis, we are going to go for frill excision. This is an exam question. Right? And after doing this evisceration, we can either put the scleral shells, which you commonly get, or any prosthesis. Both are possible. Now, what are the indications of evisceration? That is very simple. All indications of Yanov says very nicely that very clearly, all indications of enucleation are same as indications of evisceration. So now life is easy. But what is more important to learn? What are the contraindications of evisceration? Do I want to do it in malignancy? No, I am scooping out, I will leave some tumor cells. So never in malignancy. Right? I am also never going to do it if I am trying to prevent sympathetic ophthalmitis in a trauma. You remember we discussed in uveitis, any perforating injury, if I am not able to repair that, if I have to remove the eye, don't do evisceration. You may leave some uveal tissue, and what will happen? It will incite immune reaction in the other eye. So, our first aim is to repair the injury, but if it is not being able to repair, I am not going to do evisceration, I will do enucleation so that the other eye is safe. So, to prevent sympathetic ophthalmitis, you never go for, or you can say, repairing a perforating injury. Irreparable, no, repairing nahi. Removing the eye after a perforating injury for preventing sympathetic ophthalmitis. Write like this. Removing eye after perforating injury to prevent sympathetic ophthalmitis. Understood, na? So this is very important and asked in the exam. So we will put a Q also. Right? Also, after evisceration gives always a better cosmesis. Okay. So as I said, generally the indications of evisceration are indications, if I talk about, same as enucleation. That is painful blind eye. Yes. Right. Then for better cosmesis, I can do even in phthisis bulbi painful blind eye. Then for better cosmesis. Right. Then of course, panophthalmitis was contraindicated in enucleation, but yes, this is an exception where here I can do panophthalmitis, I should go for evisceration. And let's not forget what is specifically told us, we will do frill excision. Right? Iske alawa, we can also manage a bleeding staphyloma, anterior staphyloma with evisceration. Right? We don't need to mug it up, we just need to have an idea. Don't forget panophthalmitis, frill excision, contraindications where you should not do evisceration. These are some of the most important points. Okay? Right. So if we look here, so this is after evisceration. enucleation has been done here, and here this is your exenteration which was done, and how later the grafting and prosthesis has been put, right? Okay, hope you enjoyed the chapter. So just learn the notes nicely, and that's it. We don't need anything more from this chapter. So thank you so much. Stay blessed and don't forget to keep smiling.